cardiac transplantation in AL amyloidosis and ATTR amyloidosis has really evolved over the last 2-3 decades. So once upon a time, this was considered an absolute no-no, and that was because the outcomes were terrible. Patients who were transplanted were mainly patients with AL amyloidosis. It was an era with really very limited treatment options and generally bad hematologic outcomes. And with that, patients would get transplanted and they would either die from progressive cardiac amyloid in the new graft, or they would die from complications from amyloid infiltration in other organs. They often weren't screened well for amyloid infiltration in other organs. And so, though there were some that were done in the 1980s and into the 1990s, it largely became a thing that the idea was just not to do. And so what I'm going to look at in my presentation is really looking at two different eras, which we defined as basically up until 2007 and then after 2007. And the reason for that cutoff was that's really when the new era of AL amyloid therapies began, number one. And number two, it's really when ATTR amyloid recognition and, of course, much later therapeutic options took off. And so there's a variety of data sources that we can see from institutions, from national data sources, including in the United States, the UNOS registry. And we can really see how outcomes have changed over time. So where we are now is as follows, that for AL amyloidosis, you still have to be careful. You have to do extensive screening to make sure that there's not significant extracardiac involvements. You need to make sure you can control the light chains, and you want to make sure that post-transplant the light chains are controlled. It used to be that it was pretty much standard that after a heart transplant, some number of months, say 6 months later, you do an autologous stem cell transplant. I would say we and others have largely had that go by the wayside because now we can often control the light chains without putting the patient through a stem cell transplant. So extensive screening for extracardiac involvement, good light chain control, and outcomes are now, though not equivalent to the broad transplant population, they're at least at the acceptable range. For a disease that, for patients with really advanced heart failure, still has a very poor prognosis. For ATTR amyloidosis, it really is a new world. So most patients with advanced ATTR amyloid cardiomyopathy, of course, are in an age range where transplant isn't realistic. You're not going to do a transplant on an 85-year-old, of course. However, both patients with variant disease as well as some of the younger patients with wild-type disease can fall into an age range where it makes sense if their heart failure is bad enough. And so really since 2007, you've seen ATTR amyloidosis overtake AL, not only in broad diagnoses, but actually in patients who get transplanted. And the outcomes are really excellent. And I would say, broadly speaking, when you look at all of the different data sets, are quite equivalent to all-comer transplant outcomes.